Okay, I think we're going to go ahead and get started this morning. We are recording the meeting just to let everybody know. That way, hopefully, barring any unforeseen technical difficulties, we should be able to share this with folks who were not able to join us this morning. But for folks who have joined us, if you could go ahead and mute yourself, that would be great. If everybody could stay muted besides our speakers this morning, that would be really helpful. And I think most of the folks who I see here already know a little bit about EPIC, but just in case you have found yourself here and don't know anything about who EPIC is, we are a community organization that works to support the development of a positive, healthy community, reduce risks associated with substance misuse, especially as they relate to youth. If you want to learn more about us, I will put my email and our website and that sort of thing in the chat window later. If you're not already signed up for our emails, just send me an email and I can get you hooked up with that so you hear about more of these EPIC Ed events that we put on, as well as other things that we're doing in the community that might be of interest to you. Today, we're going to learn about contingency management treatment from Dr. Jeremiah Weinstock, as well as Scott Moyers, and I believe Melissa Vogelsang too today. So I'll talk more about that in just a minute, and I'm not going to talk much. I'm going to let them get started and have the majority of the time today, but just to kind of let you all know what to expect, we plan to be here hopefully for right around an hour and a half. That would be all of the speakers, as well as time for questions. If you do have questions today, if you could type those out and put those in the chat window, that would be wonderful. And then after Dr. Weinstock finishes talking, we can go through any questions that you had directly for him. And then after Scott and Melissa finish talking, any questions for them or any that you've remembered that you wanted to ask earlier as well. When we ask those questions, I can ask them for you, or I can unmute you and you can ask them in case you want to elaborate on your question in any way. So I think, at the end of the presentation today, we're going to ask that you complete a brief survey, and we'll drop a link for that in the chat window as we get a little bit further along in the presentation, and I will remind you all about that as well as we get a little further along. So at this time, we would like to welcome Dr. Jeremiah Weinstock to speak to us. Dr. Weinstock is a licensed clinical psychologist and professor of psychology at St. Louis University. He conducts clinically focused research on the conceptualization and treatment of addiction, including gambling disorder and exercise as an intervention for substance use disorders. In the context of his research, he frequently uses contingency management to reinforce behavior change, exercise behavior, drug abstinence therapy, attendance. His research includes over 60 peer-reviewed scientific publications, and his work has been funded by the National Institutes of Health and the International Center for Responsible Gaming. Over the past 2 years, Dr. Weinstock has served as a consultant for the Missouri Department of Mental Health's initiatives that seek to implement contingency management within substance use disorder treatment programs. Thank you for joining us today, Dr. Weinstock, and I am going to turn it over to you at this time.
Good morning. It's nice to see everybody here this morning, and some new friends and some old friends. So I'll be talking about contingency management, something that I am very passionate about. I have a PowerPoint slide that I'll be running people through, and so I will get started with that. I'm going to share my screen, and then let me just call up the presentation. And so really my goal is to give you a taste of contingency management, to give you an idea about what the intervention is about, and some of its empirical basis and why it's an empirically supported treatment, and hopefully get you excited to learn more about contingency management, and think about it maybe applying in your setting or as you're seeking treatment, if you're out in the community, in terms of seeing if that is something that's available at a local treatment agency. So historically, let me just talk historically what we have done in terms of treating individuals with substance use disorders. Historically, we have treated it as a illegal behavior, and it's individuals who are engaging in substance use frequently have, it's a moral weakness, and they're, individuals who are punished because of this. for this behavior. And so we have really focused on, the war on drugs was another component of that, and just terms of punishment. Go to jail, go directly to jail, do not pass go, do not collect $200. Jail was used as, instead of treatment, it was the preferred sort of outcome here. And only recently have we begun to change this by referring individuals to substance use disorders treatment centers. We now have, substance use criminal proceedings where you get referred, or substance use courts, things like that. And so we're talking here today with contingency management about taking it a step further. Let's imagine what would happen if we provided financial incentives for individuals who are engaging in substance use disorder treatment. So instead of a punishment model, we moved more towards a reward model. For example, what if each time a client provided a negative urine toxicology screen, so they provide a drug sample screen that we then assessed to see whether they were using substances. And if they were negative for their drug of choice, they demonstrated abstinence over the most recent time period, we rewarded them with a gift certificate of money. What if we rewarded individuals or reinforced individuals for attending group therapy? Maybe they don't want to go. Maybe they're very anxious socially, right? What if we rewarded individuals or reinforced individuals for meeting with a peer specialist? These are some of the questions that I'm going to ask you, and we'll be talking about today as we talk about contingency management. So the thing is, we do have a lot of punishers in substance use disorders treatment available to us today. Individuals can be discharged or kicked out of treatment for using substances. If an individual is involved with the criminal justice system, we can inform their probation or their parole officer that they're using substances. If an individual is on methadone, then in those instances, frequently they will taper somebody off of methadone very quickly and then kick them out of treatment. We do also have reinforcers that are available to us in certain treatment programs. In Alcoholics Anonymous, they have coins that you can get. So there's a coin for like 24 hours, 3 months, 90 days, things like that. Coffee, food is always a wonderful reinforcer. I frequently will show up for places if I know they're going to have a nice little lunch or some sort of spread for us, right? Social interaction, so the opportunity to see friends and hang out and talk to people. So that's another reinforcer that we have. So it's not always talking straight up about money. Treatment programs will often use certificates or praise. They have other aspects too, where they have like take-home methadone bottles. If you demonstrate certain behaviors, then they'll make it easier for that. You don't have to come to the clinic every day to get your methadone. They'll give you a week's supply and you only have to come one day. And so that's actually a reward in some way. Unfortunately, these punishers and reinforcers are frequently ineffective. All right. And the big answer here is why, and the question is why. And what happens is often these behaviors are not specifically defined. If you do X, Y will happen, right? And so sometimes the same punishers and reinforcers are used for a variety of different health behaviors. So whether it's drug use or treatment attendance or some other behavior that you're trying to change, they lump them all together. And so therefore, it's really somewhat confusing that what you'll get rewarded or reinforced for individuals. So the behaviors are not specifically defined of what was expected of you. And then there's the rewards or punishers, the consequences are used in a variety of different ways that therefore make it a little bit muddy or murky about how it goes on. And lastly, the consequences are not applied for each instance of behavior. I'm a parent, I have little kids at home, and if I don't do the same thing all the time with all 3 of my kids, that's not fair, Daddy. I get those sorts of things. And so also my kids can learn, well, maybe I can get away with it this time. Let me see if I can sneak by and do X, Y, or Z. And so that's the same here with treatment, was we have to be consistent in our approach in terms of working with individuals and doing the same things. And so one of the reasons why contingency management is such an efficacious and robust treatment is that typical CM interventions only target one behavior at a time. It has the strongest effects when providers focus on the one behavior that you really want to change, whether it be drug abstinence or therapy attendance, right? There are cases where more than one behavior is reinforced at the same time. If you're reinforcing multiple substances at the same time, abstinence from cocaine and opioids. However, the bar is a little bit higher for clients in those instances to access the rewards, all right? Thing is, if you think about it, offering rewards is not really novel. It happens in our everyday life, right? So it is frequently we get our consumer behavior. What we purchase, we get reinforced for. So Discover does 5% cash back. Not if you use your Amex card, But if you use the Discover card, that is the behavior they're reinforcing. Starbucks has a reward program. Southwest Rapid Rewards. I like the word rapid in there because it means it's going to happen quickly, right? There's also employees. We all do things because we want to work, because partly is because we want to earn money, right? And some people work on commission, or there's awards, or there's social praises. There's maybe opportunity for promotion, and that can be a reward for some individuals. Children, we frequently will engage in reinforcing behaviors around star charts. So if you do X behaviors each day, so I'm working with my children about making their bed, and they get a little sticker at home on the chart, and after 5 stickers, they get a prize, right? Special foods or allowance. So you do X chore, you get Y allowance, amount of money. If you think about it, rewards or reinforcement is used when you're training dogs. And so when you are training them to use the bathroom outside, or if you want to have them sit and heel, we use behavioral reinforcement paradigms all the time with dogs. And so this is not necessarily novel or new, what we're doing, but we're applying it in a somewhat novel sort of context in terms of what's going on. So there are some fundamental sort of principles of contingency management when we're doing these interventions. And so if we want contingency management to be effective, it has to have 3 central tenets. Number 1 is when you're thinking about a target behavior that you want to change, you have to frequently monitor this behavior. You have to assess it regularly, multiple times per week, or at least once per week, so that the person has the opportunity to demonstrate adherence or compliance, depending on the word you want to use. I prefer adherence with the behavior there. And so therefore you have to frequently monitor so that you can then, when they do demonstrate the behavior, you provide that tangible, something they can hold, something they can see, positive reinforcement each time that target behavior is demonstrated, because we want to reinforce that behavior regularly and consistently over time. And then lastly, when individuals do not just demonstrate the behavior, you withhold the positive reinforcement. And you can even add in a slight punisher along those lines. And so contingency management is all about thinking about what is the important behavior I want my client to engage in, and providing reinforcement when they demonstrate that behavior. And when they don't demonstrate the behavior, they don't get access to the rewards, and there may even be a slight punisher. We're not talking about like a cattle prod, electric shock sort of thing. What we're talking about more along these lines is frequently use money, gift certificates and things like that to reward clients. And those gift cards escalate. The amount of money that you can earn escalates over time because we're demonstrating consistency of behavior. And when they don't do it, that monetary amount resets back down to the bottom of your reinforcement schedule. So that's what we mean by a slight punisher along those lines. All right. And so we really want to make sure when we do a contingency management intervention, it has these 3 components, because these 3 components are really what will make contingency management effective. So I've been describing contingency management now. What I'd like to do is now just show a short video of what a typical contingency management session will look like. And this is a prize-based contingency management session, just so you know. There's several other types of contingency management interventions sort of schedules, but I'm just going to show you this prize-based contingency management. I'm the therapist. This is a colleague of mine, and we're reinforcing drug abstinence in this example. All right, Carla, welcome back.
Hi.
I have your urine toxicology screen sample here. All the validity checks look good, and it says that you're negative for stimulants. Nice.
Yeah.
Good.
This is the longest I've ever gone, I
No
think.
way.
Well, you know, except being in jail or something, but on my own, sure.
And you're out in the world and you're having some opportunities potentially to use, or you're having some cravings or some desire, and you're not doing it.
I'm excited.
That's really great news. This is what I love about contingency management, is we get to see this progress, you know, and we get to talk about it on a regular basis. So that's really awesome. All right, so I'm going to share my screen because I want to pull up the reinforcement schedule just so we're on the same page and you see everything that I see. All right, so This is week 3, sample 2, and you get 6 draws.
Yay!
For the longest absence you've had. So this is great news. So let's just do that right now. We'll do your 6 draws. All right, so I'm going to hold up the bowl, mixing it all up for you. All right, so here's 1, 2, 3. You can see I'm just pulling. 4. I hope I'm doing a good job for you. 5 and 6. All right. So let's see what it says. Small Small prize.
Ooh,
All right, that's number 1. 2, good job. Because
Okay.
you are doing a really good job. And we wanna
I
keep
am.
doing that. Small prize.
Ooh,
All right, all right. Small prize.
yay!
All right, so you're already at 50% winners.
50-50.
6 slips. You got 6 slips and you're already at 3 small prizes. Make that 4 small prizes.
Wow.
All right, and then, good job.
Okay.
All right, so you have a total of 4 small prizes. Each of these are say small prize on them.
Yep.
Yeah, and then you have the 2 good jobs. All right.
Okay.
So what are you thinking about for your small prizes?
I want 4 of those hand sanitizers.
Good deal. We will definitely do that. I have them right here. So we have a stack of them. I'm going to put them in a bag and have it up at the front door with your name on it. So
Wow.
give me 2 minutes just to do that. And I have to log them out and stuff like that, you know, just that sort of thing. But I will take care of that and I'll be out there in 2 minutes. So if you just have a little patience, I'll be right there.
And when do I see you next?
That's a great question. I'm going to see you on Monday because today's Thursday. So I'll see you on Monday. And you got 6 draws today. So it keeps going up. So on Monday, you're going to have 7 draws if you're negative for stimulants, for cocaine.
Yay!
I'm really looking forward to it. I hope you're able to continue working really hard and remain abstinent.
Thanks. I'll see you Monday.
See you Monday. Bye. All right. So this is an example of a typical prize-based contingency management session. What you can see is that the individual provided an observable behavior that we were tracking, and we're frequently monitoring it twice a week. And you can see that the individual then, through my language, I am specifically linking the drug abstinence to the number of draws that she receives out of the fishbowl. Prize-based contingency management uses a variable ratio reinforcement schedule where not every slip in the prize bowl is associated with a prize. It's one of the ways we keep our costs down. But through that, they have the opportunity to win prizes. And in this case, this is during the height of the pandemic when we filmed this. And so the little, these little hand sanitizer things were the valued prize at the time. And so I want to say that the VA system uses this prize-based contingency management nationwide in their substance use disorder treatment clinics to reinforce stimulant abstinence, so cocaine and methamphetamine abstinence in their outpatient substance use disorder treatment programs. There are also other efficacious contingency management reinforcement systems. Currently in the state of Missouri, we're using the voucher-based contingency management reinforcement system, and that is where an individual is given a set amount each time when they demonstrate the target behavior. So it starts off at like $5 and it escalates to 7 to 9 to 11. It just keeps going on a set schedule. And that is efficacious as well. And you can use a program like that along those lines in terms of all that sort of thing. So that's just an example of contingency management. Now I'm just going to do a quick review of what we know about based on the empirical literature, the scientific literature about contingency management. And so just to give you a couple quick tastes, there's tons and tons of studies out there and clinical trials on contingency management. I'm just going to hit a couple of high points that are exemplars of the larger literature that are out there. And so the first thing we know is this is a study from 2016. It was outpatient treatment for cocaine use disorder. And they collected urines 3 times a week for 16 weeks. And so all they were doing was reinforcing cocaine abstinence. Here, contingency management is paired with cognitive behavioral therapy, CBT. And when you're offering individuals the opportunity to earn prizes or to earn gift certificates, one thing we always find is that individuals stick around in treatment longer, even if they're not always necessarily generating an extended period of abstinence. Contingency management retains individuals in treatment for longer. There's less of a dropout over a period of time. So that's just a byproduct of what's going on with contingency management. In terms of abstinence, CBT plus contingency management is much more effective in creating this period of abstinence. In this sample, about 75% of individuals achieved 3 or more weeks of continuous abstinence versus it was less than 40% in the individuals who were just receiving contingency cognitive behavioral therapy. And this is really just a typical sort of what you would expect to see, that when you offer contingency management to reinforce a behavior that individuals are struggling to adhere to, adherence jumps up to be from, typically behaviors are somewhere around 40%. It jumps up to somewhere north of 60 to as high as about 70, 75%. And so you do see this big sort of increase in adherence in terms of contingency management. It's still not a panacea. It doesn't work for everybody. There's still a chunk of individuals, 30 to 40% of individuals who do not respond to contingency management. And so we kind of have to set our expectations that this is not going to be 100% perfect. One of my favorite examples of that is there's a contingency management trial that took individuals who had gone through the standard contingency management intervention and did not respond to contingency management. And they were reinforcing cocaine abstinence in a urban inner city methadone maintenance sample. And they turned around and said, okay, we're going to offer you $3,500 over 9 weeks if you can generate a period of abstinence from cocaine. And only about 45% of that sample was able to do that. There's something so reinforcing about cocaine that they rather use cocaine than get $3,500 over nine weeks. Personally, there's a lot that I would do over 9 weeks for $3,500, my own little world. So just to highlight that sort of aspect. But I think that talks a lot about the pull and how strong cocaine use is and what is going on in individuals' lives, that is not something that they would actually really consider and change. All right, that something is going on in their lives, and just how for many individuals, substance use is not a volitional act. And so I want to really highlight that as well in talking about that study. Other example, this is from my own research. I frequently reinforce exercise behavior in individuals with substance use disorders. These are individuals who are non-treatment seekers. So individuals who are not seeking treatment for alcohol use disorder, we told them that they had an alcohol use disorder, and we said, you should go to treatment. They said, no, thank you, I'm not interested. And we said, well, how about you start engaging in an exercise program? They're like, okay, I'll do that. And so what we find here is that, lots of people know exercise is great, and not many people do exercise. And if you are sedentary, it is really hard to start exercising. So everybody at our study was exercising at less than once a week at the beginning. And then individuals either received a YMCA membership or a YMCA membership plus motivational interviewing and contingency management. Here, CM is being blended with motivational interviewing. So just a different therapeutic approach from CBT. And what we find is that there's increased adherence to exercise. Exercise frequency goes up to what the public health guidelines of 3 times a week or 150 minutes or more of moderate intensity exercise. And they're able to sustain that over a period of time. All right. And so then also just going in some of the other sort of empirical literature, there's things called meta-analyses where they combine a lot of different studies and see what the average result is. And what we find is that when contingency management is paired with cognitive behavioral therapy, it has the strongest effect size. An effect size of 1 is pretty large versus contingency management by itself is still pretty strong. It's above 0.5, which is still considered a large effect size. Cognitive behavioral therapy by itself is a small effect size. Relapse prevention also has a small effect size. So contingency management is one of the strongest behavioral interventions or psychosocial interventions we have. But some of the details of how contingency management is delivered really matter. The first one is the magnitude of reward. So how much money are you offering individuals? The more money you offer, the larger effect size you will have. At some point, it doesn't matter. As I just told you earlier with that one study where individuals had the opportunity to win $3,500 over 9 weeks. But you have to have a sufficient magnitude or dose of contingency management for it to be effective. The other thing that's really important in delivery of contingency management is that the reinforcement must be delivered immediately. So as soon as possible after the person demonstrates the target behavior, you're providing the reinforcement. Versus if you're waiting a week or 2 weeks for them to get their reinforcement, it's less likely to do that. So you want to just pair the behavior with the reinforcement as closely in time as possible. That's another important sort of design feature when you're thinking about it. It basically means that design interventions sort of matter. So you're thinking about this, I'm okay, CM's pretty cool. I think I might like this. But the thing is, you're then going, well, what happens though when the reinforcement goes away after you stop doing this? And that was a big concern early on. And so this is an older study, but what they found was that individuals at 1 year follow-up, this is paired, contingency management in this study was paired with community reinforcement approach. It's another psychosocial intervention. And what they found was that CM individuals at 1 year follow-up were more likely to be abstinent from substance use, and this is stimulants again, were more likely to be absent at 1 year follow-up compared to when it was just community reinforcement approach by itself. And what we know is basically abstinence begets more abstinence. Basically, individuals who are able to start a period of abstinence during treatment are more likely to have it stick, because other reinforcers sort of come into play. If family starts to trust you, you actually start to like being abstinent. And it's actually, you enter into a period of what we call full recovery. All right. I'm going to briefly hit now on sort of other behaviors that you can reinforce. So there's lots of substances that you can have an individual demonstrate absence from, and these all work for contingency management. The two tricky ones here are benzodiazepines. They need to be medically monitored if they're going to be taken off of benzos, because individuals have potential for seizures. Marijuana, our current urine toxicology screens, if someone's a heavy user, it takes about 2 weeks of absence before an individual will actually show drug absence on a urine screen. So you have to kind of plan for that 2-week period where they may be abstinent, but their drug screen is still showing positive for recent use. And so that's just a little special concern that you have to think about. Non-substance sort of behaviors that we can reinforce are treatment attendance, engagement in therapeutic activities outside of the thing, like such as going to a probation and parole officer meeting, going to your doctor's appointments, engaging in sort of pro-social behaviors, things like that. Medication adherence is another important behavior that CM has been shown to be effective in increasing. Exercise is my own sort of line of research and shows that we can get people up and active and meeting the public health guidelines. Beyond substance use disorders, CM has been used in diabetes in terms of glucose monitoring, in terms of individuals who are struggling with obesity. You can do it for weight loss. So you have to be very careful about making sure people are not losing weight too quickly. So you have to specify that. Just in terms of walking, getting people up and moving and having them do 10,000 steps a day. Health screenings and vaccinations, we're seeing that a little bit with COVID, where there's opportunity to win prizes. But you really want to have that really paired closely in time to when the behavior happens. All right. So the thing is, what populations respond to CM? It sounds like CM really works, and it does, and it works for a lot of different people. There's no effect in terms of treatment outcome, any differences based on an individual's income. All individuals respond, no matter which income they have, to contingency management, as long as it's of some sufficient magnitude. There's no effect by male or female status, so gender, no race or ethnicity effects. Individuals with greater psychiatric severity actually tend to do a little bit better in contingency management because it's a very straightforward, basic behavioral sort of intervention. It's not very complicated. Promotes retention for those with multiple prior treatment admissions. So those individuals are more likely in some instances to give up and quit even when they hit their first sort of barrier or challenge. And contingency management helps them be retained in treatment. And if you'd like a much bigger academic review, there's these 2 review articles that I recommend. And so I want to highlight that. And then one of the last points that I really want to hit on is that when you're doing contingency management and you're reinforcing one behavior, there can be ripple effects to other health outcomes that may be of interest. For example, we did a study about 10 years ago in individuals who had substance use disorders and were HIV positive. And we reinforced drug abstinence in these individuals. And individuals who were able to achieve drug abstinence, what we found was that improved their CD4, which is a marker of their immune system functioning, and their viral load counts. That's basically how many copies of the HIV virus are floating around their bloodstream. And what we found is that the CD4 count went up, which is a good thing, and that their viral load counts went down as a result of their drug abstinence. And contingency management was more likely to generate that period of absence where we're going to have these good outcomes. And another study that I've done is we were taking sedentary, non-treatment seeking individuals with alcohol use disorder. We're engaging them in exercise and reinforcing exercise. And we found that individuals who engaged in exercise had reductions in depression, which is a very common finding. Exercise is as efficacious as taking an antidepressant medication in terms of treating depression. We also found reductions in blood pressure, because exercise has that wonderful benefit as well. So CM can have these ripple effects depending on the behavior that you're reinforcing. So sometimes you want to think about those sort of secondary effects. So my main summary here is that CM is an empirically supported treatment, typically offered as an adjunct treatment to other treatments, except in the case where I was engaging non-treatment users, non-treatment seekers. It helps clients initiate a behavior change that is otherwise very difficult. If our clients could change their substance use behavior, if they could create a period of absence, they wouldn't come see us, right? They would do this on their own. And so, or any other behavior that you're thinking about reinforcing, many times individuals just struggle with that and they need that little extrinsic push. And what we do know from the health behavior change literature, that extrinsic motivation really helps individuals start a behavior change. What generates long-term adherence is intrinsic motivation. And so what I want to say is contingency management provides that window of opportunity for other reinforcers to develop and start happening, and also for other skills that therapists may train individuals in to become ingrained. And so contingency management kind of just creates this window of opportunity along those lines. So by this point, hopefully I have sold you on contingency management, but you still may have some questions or some ideas here. And so I want to hit on sort of the top 5 barriers that people sort of identify when they're thinking about contingency management. One of them is that they're worried about what happens after the contingencies are withdrawn. So at the end of that 12-week period, when the reinforcers go away, what happens? And hopefully I've shown you that abstinence begets more abstinence. And this same is true with exercise or other behaviors, is that they start to do these behaviors for their own sake and for reasons that they want to do. Another reason is people say, well, you're talking about paying patients or clients money. Where are we going to get this money? And what research has shown is that individuals, if you're doing this like in a group treatment setting, is what happens is people stay in treatment longer. And so you don't have the typical attrition that you normally would experience. And so you have the same fixed costs of offering group treatment, but instead of only having 5 patients for 12 weeks, you're now at 8 to 10 or even 12 patients across those 12 weeks. And so that increased billing that you receive for those individuals who stick in treatment help pay, basically contingency management therefore pays for itself. Research evidence does not apply to everyday clinic populations. People typically say, well, that was a very, a really well-resourced study. I don't have those same resources, or they don't know my clients. And what I say is contingency management is really robust and we can adapt it to your setting. And then individuals will sell or trade items for drugs. And the thing is actually, if you're reinforcing drug abstinence, as soon as they use drugs, they're going to lose access to that reinforcement. And so that doesn't typically actually occur. And they've done studies actually where they pay people a very high amount of money, and then they test them the next day just to see if they're using, and they don't. And so that's another sort of obstacle that we can overcome. And then lastly, people say, well, that undermines individuals' intrinsic motivation to change, right? You're paying people to do something that should do on their own. And so they're not going to want to do it once that money's gone. And what I say is actually, this really creates that opportunity for that intrinsic motivation to change and to continue doing this behavior really sticks. So the bottom line is these beliefs are modifiable, and we have research evidence to kind of say, well, let's think a little bit critically about this, and let's see what the research literature has to say about that. So at this point, I'm going to conclude my talk. I just want to say thank you. And if you're interested in learning more about contingency management, there is a book out there. It's called Contingency Management for Substance Abuse Treatment by Dr. Nancy Petrie. Dr. Petrie is one of my mentors. I have no financial benefit with this book, but it's a very clinician-friendly book if you're interested in figuring out how to implement contingency management in your treatment protocol. So at this point, I would like to sort of open the floor for some questions and dialogue. I'm going to stop the share so that I can see people and see the chat much better. All right. Please either put something in the chat or throw some questions my way.
Yeah, thank you so much for that. That's super interesting. And I hope people have questions, and like Dr. Weinstock said, put them in the chat, or you can even just open your mic and ask as well. But I do have a question. How do you ensure that, especially in a group setting, how do you ensure that what you want to use as a reinforcer is in fact reinforcing for the individual? It seems like in a one-on-one session, you might be able to kind of identify what's really going to be reinforcing for one person, but in a group setting, if you want everything to be kind of very similar, how do you make sure that it is not just an extra nice thing that you're giving to somebody, but something that really is going to reinforce their behavior?
So that is with any CM system that you do, contingency management system, your reinforcers have to be desirable, right? And so that requires a little work on the front end of just talking to your whoever your group is going to be, your patients of what group that is, and finding out what is reinforcing. Cash is always king. And so that does work. Gift cards are wonderful things, and having a variety of selection, Walmart, Target, local grocery stores, local gas stations. Those are sort of the big four along those lines. But then there may be other things that individuals really specifically desire. And so you may want to do that. The prize-based contingency management, when in its first iteration, didn't really use gift cards. We had actually different stocked items like these hand sanitizer things. And so you would want to talk to your patients ahead of time about what was really popular. When I was in Hartford at the University of Connecticut, working at inner city Hartford, bus tokens were really important reinforcers. We're doing another one with adolescents and so teenagers, and the teeth whitening strips were the big, huge hit. So you just kind of have to know your population that you're working with and talk to them and see what's reinforcing for them. Great question.
And I guess if you noticed that maybe you weren't having success or something too, that might be somewhere to look, would be to adjust the reinforcement or to do a little bit more digging.
Yeah, if you're not having success, one is I just make sure, are your reinforcers motivating, having a sufficient magnitude too as well. And so, but sometimes there's external constraints on how much money you can offer, depending on your funding source and the streams that you have available. And I didn't put up this slide, but there is, we did a study, this is again a little while ago, but we looked at when do people respond to these reinforcers? How quickly did they start to engage in behavior change? And it happens within basically the first 3 to 4 weeks that contingency management's offered. If it doesn't happen by that point, it's time to move on. I mean, there's nothing worse than, to me, it's like the definition of insanity that you're testing someone's urine for 12 weeks straight and they just continue to test positive, and you just sit there and keep saying, well, next week when you come in, if you're negative, you're going to get this, these reinforcers, right? And so that to me I was really frustrated by that. I'm like, well, so when does this happen? And what we found is it happens within the first 3 to 4 weeks. And after that, it's sort of like almost like a step care model. If that's not working, it's time to switch to something else and try a different approach, because contingency management doesn't work for everybody. Mm-hmm.
Well, I am not seeing any other questions in the chat right now, but maybe folks will think of some as we move along. Go ahead. Sorry.
I was just also, I know we're going to move on, but I wanted just to add one other thing. It's really important as a therapist is that you have to consistently reset people when they do not adhere to the behavior. And it is no fun when you do that. And it isn't. And clients get upset at you. I've had a client yell at me for a good 5-10 minutes. Even worse than when my mother ever yelled at me. And so you have to really kind of stick to that and understand that and just know that that's going to happen, but it's for the best, because once you set that bar, they do come back and they will hit that bar. Linda, please go ahead.
This is basic for me. And I hope I can phrase it correctly, but is it the nature of the relationship between you and the client? Or, for example, what if, I'm just trying to understand in what kind of a relationship would this work? Like we're not talking parent to teenager, or do you see it outside of, professional client, professional relationship? Is this theory, does this behavior change occur in those types of relationships too, or not?
Yeah, so these are basic behavioral, straight up behaviorism. Like if you go back to the B.F. Skinner back in the 50s and training pigeons to, knock a ping pong ball around, and rats to press a lever. It's all these same basic principles that are applied today. So these same behavioral principles are used in autism. The ABA therapy is the same, basically, as this. The same is true if you do an allowance system and it works, then it's following these same basic behavioral principles. This is why you see contingency management moving into health behavior change beyond just substance use. They also have used, contingency management sort of traces its beginnings back to also inpatient wards in the 70s and 80s had token economies where individuals had to get up and do the activities of daily living, like They had to shower, they had to be out in the group room by a certain time, and they had to do certain things. And then they would get privileges based on the number of points they earned each day. And privileges were frequently smoke breaks. But that was, 70s and 80s. We don't do that anymore. But yes, you can, it's these same basic things apply in lots of walks of life.
Okay, then a follow-up to that would be, like what we teach our nursing students is, we try to help them learn to use the SBIRT model, and, how the willingness to change, and, this contemplation of where are you at right now on your willingness to even consider change. Does that come into play with this as well? Or is that a question that even comes up when you begin to consider this with a client?
So that's a really good question. I think what we know with contingency management, I have a buddy, his name is Dave Ledgerwood, and he actually looked at a study kind of addressing this question. He looked at stages of change, and does contingency management affect stage of change just by itself? And David called this his Seinfeld study. Seinfeld was a TV show about nothing. His study was about basically showed nothing in terms that contingency management doesn't necessarily change an individual's stage of change, but it does get them to adhere to the behavior for the most part. You still have that 30 to 40%, and those are those people in pre-contemplative. It doesn't move them along. Like motivational interviewing will potentially, if you do it well, and it doesn't work, even when you do the best motivational interview, you don't necessarily move someone from pre-contemplation to contemplation. I use MI a fair bit in my own work too. And so it works for people who are in that contemplative. It works for people who also just need that extra little push, or they don't have that belief in themselves that they can do this. And then you dangle that in front of them, they find a way to make it work. What I personally think that happens with contingency management, especially around drug abstinence, is it puts up a little bit of a barrier in the sense that they're in a moment where they're craving, or they hit a cue, and all of a sudden they have that strong desire to use. And CM interrupts that little process by saying, oh, I have to provide, my clients would say, I have to drop a urine tomorrow. I can't use today. It just slows down a very automatic process for some individuals and interrupts it and gives them something to think about, so that automatic process of use doesn't go on. And it's the same for exercise. I've seen my clients saying, like, I don't want to go, it's raining today, but if I don't get my workout in, I'm not going to get my draws. Right? I'm not going to get the reinforcement. So it's just that extra little push, I think, that it really provides.
Thank you.
All right.
All right. Well, thank you, Linda, for those questions. And thank you, Dr. Weinstock. We are going to go ahead and move along to the next part of the presentation now. And if folks have questions after this about the first piece of the presentation or about this second piece, we can ask those then after this. So I would now like to welcome Scott Moyers and Melissa Vogelsang to share with us about a contingency management treatment program that is actually happening at the Gibson Recovery Center right now. Scott is a CDAC CPS and a MARS, and serves as the Director of Clinical Support Services at the Gibson Recovery Center, where he oversees the agency's certified peer specialist and behavioral health assistants. As a person in long-term recovery, Moyers brings his lived experience to his role and his unique experience as a former consumer and person who struggled with addiction for 2 decades. Moyers has been employed at the Gibson Center for 4 years, working his way from a part-time behavior assistant to now serving on the management team. Moyers is also one of the team leads that has implemented the agency's contingency management program, which now boasts 15 active consumers. And he is going to be joined today by Melissa Vogelsang, a licensed professional mental health counselor at Gibson Recovery Center and the Director of Medication Services. So I'm going to mute myself and turn it over to you two now.
Thank you, Shelley. We also have a third member of the lead team on the call. Shonda Hemphill is the Chief Behavioral Health Officer. She's waving, if you can see her. So I'm just going to go ahead and get started and share my screen. We also have a PowerPoint we're going to go through. Okay, so this is, Dr. Weinstock did a great presentation. We got to know him as we implemented this program. He was sort of our technical advisor. And so we met with him very often at the outset. He had a lot of good input and suggestions as we were implementing our program. And so just a little bit of background, I know that the opioid crisis is, takes all the headlines, it gets all the attention, but stimulant use disorder is a major problem in our catchment area here in Southeast Missouri. In fact, Cape Girardeau County was recently ranked in Missouri's top 10 for the percentage of substance use disorder admissions with stimulants as the primary substance, and that was around 34.3%. Here at the Gibson Center, the percentage of SUD admissions with stimulants as the primary substance is just a little bit below that at 28.8%, with many more of our clients getting a STIM-UD secondary diagnosis. And so the predominant stimulant type for our consumers is methamphetamine. We just see a huge influx of consumers that use methamphetamine with various routes of administration. It sort of varies across the spectrum, whether they are smoke it, which is about 43%, IV use, which is about 37%, and inhalation 16%, and then just orally at 0.03%. And as you guys are all too aware, it's sometimes fatal. In Cape Girardeau County, one person died of methamphetamine overdose in 2018. A lot of our clients sort of have this mistaken belief that you can't overdose on methamphetamine, so they feel it's sort of safer, but that's not true. And then the year after that, in 2019, 3 people died. And those numbers seem, relatively small. We know one death is too many, but there's just countless others in our area whose lives are just ravaged daily by this drug. I am an example of that. My primary substance was methamphetamine there at the end, and it is totally a destroyer of everything that was meaningful in my life. So whenever we were talking about maybe participating in this program, we knew that there was this need for these new innovations and approaches, such as contingency management, to sort of help engage and retain our clients who struggle. I think Melissa's going to talk about this slide.
Yeah, and I also wanted to touch on the overdose rates for methamphetamine it's on the rise. What we're seeing a lot, so just recently, I run the medication assisted treatment program here, and we recently got fentanyl testing, and thank goodness we did. So a lot of our consumers whose primary substance is stimulant are now testing positive for fentanyl as well. So these numbers are going to continue to rise. The importance of this, it's just astounding, the overdose numbers. And, we see a lot of stimulant use disorder at Gibson. And I know Scott already touched on that, but it's not just a lot of our consumers, probably a third, or that's their primary, but with many more as their secondary. So, I know Dr. Weinstock already touched on CBT, but that is what we try to utilize with these consumers. It enables individuals to understand their current problems, challenges, and experiences to change their behaviors as well as their thinking patterns, and develop accurate assessments of circumstances and their feelings to create realistic strategies and goals. So we want to engage and treat people who actively use stimulants in withdrawal or early recovery. And it's a type of behavioral therapy grounded in the principles of operant conditioning. I know this was already covered too. And so it's a method in which desired behaviors are enforced with prizes, privileges, or cash. In our case, we use gift cards, and we found that, and we're going to touch on that a little bit later, but it's very empowering for our clients to be able to pick which prize they get. And studies demonstrate that the use of CM for people with stimulant use disorder caused reductions in the following areas: number of days of stimulant use, stimulant cravings, new stimulant use and risk behaviors. And we've had a really great response to this program in a very short time. Our numbers are growing as far as the clients getting into the program, and we've had just great luck with it. So we were really excited to start this process.
And so we actually implemented CM after we'd actually written this grant proposal, got selected. And so we went about getting it implemented in July of this year. And we decided to use these gift cards for some of the very same reasons Dr. Weinstock was talking about earlier, as reinforcement therapy to sort of encourage these positive behavior changes. And we sort of thought that it would be this tangible reward when they meet the specific treatment goals that we were talking about at the beginning. So our program was introduced as an 8-week pilot, and it was, the grant only funded 4 weeks, but we were such a believer in this process that we decided to fund an additional 4 weeks. We had an original goal of trying to get at least 75 consumers enrolled in contingency management. And so that would all occur during a consumer's first 60 days of outpatient treatment. So yeah, we started in July, and we saw immediately the potential to improve outpatient engagement and retention. And so we had this historically high no-show rate in our outpatient offices. And we were, we know we offer them excellent counseling and peer support and case management. So we were struggling a way to get them engaged and then to keep them engaged. So I know that Shelley had said that we had 15, but even since that time, we've enrolled 27 clients who are enrolled in SOR 2.0, which is what the name of the program is, which is a contingency management program. So, he was saying that it's not for everyone. And one of the things that we've struggled to figure out is we've had 27 of those consumers that enroll in, who are, the program is explained to them. They seem like a good number of them seem like they're interested. Some of them have just declined to participate, even though when they enroll in our services, they say they want to meet with a counselor and they say that they want to meet with a peer specialist and a case manager. They're still not interested in contingency management after we explain it to them. And what we've seen is that those who were not interested in contingency management really weren't interested in coming at all. And so we have learned that they have enrolled in our services at the behest of a probation officer or a loved one, and they really weren't interested in any of our services. So while a small number of those are technically enrolled in SOR 2.0, they're not coming at all. So we don't see that as a liability or anything that speaks to contingency management as a whole. And so we do enroll them into the program during the eligibility determination. And so the criteria for us is they have to be diagnosed with a stimulant use disorder. And there's a definition. It's the continued use of amphetamine type substances, cocaine or other stimulants leading to clinically significant impairment or distress ranging from mild to severe. And they also have to be uninsured.
So this is an example of what we give our clients who will receive contingency management. And Scott's going to get more into this, but we decided 2 sessions a week. The client will be seen, but this would be in their first session, or we can give it to people who may be interested. So this is kind of just a repeat of the information. But this is just an example of what we give to each of our clients, as well as staff members, just to keep them on track.
And so whenever they meet with a licensed counselor for their eligibility determination, and they're placed into this open enrollment for SOR 2.0, that's it. Whenever they meet with actually support staff, they're put in an open enrollment, and then they meet with a licensed staff who refers them to me. And so one of the things that we do is, and then I refer it to various staff for actual casework. And so we give them a contract. We think it's important to get that commitment from our clients, is to totally explain exactly how this is going to work and have them sign it. You guys know that there's something sort of intrinsically sort of meaningful is when you sign your name to something. It's a commitment. And so the contract outlines who the staff they're going to be working with, what the requirements are, the duration of the sessions, which staff they can meet with, which in the case of the Gibson Center is either a counselor, a case manager, a community support advocate, or a certified peer specialist. And so they can see exactly each week, and for each session, they don't get a weekly total, they get a session, they get that money loaded onto their card, and I'll explain some more about that in a minute too. Each session, so they immediately see the benefit of that, that reward. So that's just a copy of the contract. And so just to briefly take you through the intake process, like I said, earlier, is our support staff. Whenever somebody sets up their appointment, we put them in the SOR 2.0 program if their primary struggle is stimulants. And then the diagnostician will meet with them and do the eligibility determination. They'll discuss contingency management with the consumer, give them the handouts, answer any questions that they have, and then they'll email me the client's name and information. And then I would assign it to a peer staff, sort of for handling and oversight. So we have, peers that are assigned to each location that we work in, and that's Sykeston, Perryville. We have one at our Linden location, and we have one at C-Star. We've had some staffing issues that have occurred since we started this that created some obstacles, but we've created workarounds. And so just for example, we no longer have peers in Sykeston or Perryville, and that's not by design. That's because just through staffing changes, we're currently looking to fill those positions. So that sort of put us in a tight spot in the moment, because the peers were handling a lot of the work with these clients. So we had to shift temporarily, hopefully, to community support advocates. So it hasn't been all smooth sailing, but we were able to quickly, ensure continuity of care so that the clients are still getting their incentives, still seeing counselors and now case managers in the outpatient offices. And in CAPE and with the men's program and the women's program, they still have peer support staff that'll be working with them. So whenever the consumer, we let them know early on that they're going to be responsible for informing the agency of their progress and the services that they attended. And so they sign this tracking sheet that I'm about to go over with you so that the appropriate amount can be given to the client. So this is just an example, a sample of what the client has as far as a tracking sheet. So the staff signs it, the time of the session, and the incentive earned, so that the client sees exactly, how they're doing in the program. One of the things that Dr. Weinstock suggested, I had never heard of Tango gift cards, but he had said that might be something that we would be interested in, and it turned out to be just this amazing tool to get the gift cards to the clients. And we don't have to, initially we had talked about going to Walmart and buying bulk gift cards and other places like that. But Tango, we can download money onto our account, our Tango gift card, and then send the incentive to our consumers via email. So all we need is their email address. And so they'll get an email saying that here's your incentive. They click the link and it brings them up over 100 different sites, businesses, restaurants, Walmart, all of these things for them to choose from, so that it empowers them to be able to spend their money however they want to, like Apple, iTunes, any way that they want to spend it. So that's been, the consumers are very pleased with that. Melissa, do you want to talk about the focus groups?
So at the beginning, when we applied for this grant, we decided to do focus groups with staff members and consumers. And I was thinking, okay, focus groups is just something people say they do. And so Scott and I were really, really surprised at the response that we got from our clients. So we just sat down with them and asked them, we kind of explained what contingency management is. Most of them were not familiar with the term. And most staff, quite frankly, had limited knowledge. But we described it and interviewed staff and consumers, and all were in favor of this. And consumers reported that such a program would indeed motivate them to participate. They gave us a lot of great feedback. I remember we had to cut down the quotes that we had. That we could actually put in to the grant, because we had just so many great quotes from the consumers. And we learned very quickly that that our clients, this is something that they would be in favor of. And several staff members, in fact, once that was explained, they were very excited. So we have had the luxury of being supported. This is not a huge agency, but we have about 100 staff here. Scott and I did a lunch and learn for all of Gibson, and we just got a lot of support from staff members, and everyone's on the same page with this. So it's been really great.
Sorry. And so we had, like she said, we had so much positive feedback, and clients were very interested in this. And I can tell you the amounts initially seemed small, but I know that whenever I was first getting into recovery, I didn't have anything. And so a $5 gift card would have meant a lot to me. And in fact, whenever I went through drug court, I'm a graduate of the drug court treatment program, and they would give gift cards, like if you, and I noticed that other people were getting them and I wasn't getting them. And so even though those were $5 gift cards too, whenever I got one, I think it was a $5 gift card to McDonald's. It wasn't just about the gift card. It was the recognition in front of my peers and in front of the drug court judge that meant something. That recognition meant something to me. And one of the clients told us, we just need an extra reason sometimes. And as you all know, getting sober is not easy in the best of circumstances. So recognition, validation, all of these things are super important. And another client told us, this is like giving recognition, and we all need that. We also talked to almost all of the management team and many other staff members, because we had a concern early on that Dr. Weinstock also touched upon, that there would be some resistance from staff, because why are we paying clients to do what they should be doing already? And that turned out to be totally unfounded. Just a couple of the quotes from the focus groups that we got. One was from our director of clinical research. Her name's Ashley Nagger, and she said, contingency management is a versatile tool. In some cases, CM may be the only hope to get clients engaged in our services. Many of you know Janice Rusler, and she's our director of outpatient services. She had used contingency management in the past whenever she was the director of a program here called Hillcrest. And it was one like Dr. Weinstock was showing in his video, where you could pull little cards out of a fishbowl and get rewards from that. And she found that clients were more engaged in treatment and were more motivated by the positive feedback and the rewards they were able to learn. And she said in her case, that led to better treatment outcomes overall, in that contingency management has saved the lives of people struggling with substance uses by teaching them that positive behaviors connect to positive outcomes. And so she was a believer from the beginning, and we got nobody that sort of met us with this position of resistance, so we were pleasantly surprised by that. And so I did want to add a couple other things real quick before we wrap up, is that I think we neglected to mention that our attendance was the thing. And I don't think that we were even capable of using drug screens, but we wouldn't have wanted to do that anyway, even if we could under this program. We wanted attendance, because as Shonda put in the chat, that we wanted to reach our consumers through expanded treatment and harm reduction approaches. And so we just wanted to get the clients in the door. And it seems like that if we could get them in the door, we have the qualified trained staff, whether it's a peer specialist, a case manager, a counselor, to keep them engaged in treatment. And we know that as long as they're engaged in treatment, their chance of success is so much greater. We have had one consumer complete the 8-week program. And like it's 8 weeks, so it's taking them a little longer. The rest of our participants are anywhere between week 1, week 4, week 5. And whenever the one person did complete, we had a little graduation ceremony for them. It was over Zoom, and we made him a certificate, and he was on the call with me, and at the time the peer specialist that was employed here, and we just bragged on him and commended him. And I just checked yesterday, he's still engaged, he's still coming for appointments, even though there's no longer any incentive in it for him. So we've seen here that it works, and it really is working for our clients. Is there anything else you wanted to add, Melissa or Shonda?
No, we just love it. And we love the support of Dr. Weinstock through this. And he's the master. So.
And one other thing I should add too, we have had a couple of people who missed. And one of those was, he was hospitalized. And of course, we should have known this, that, okay, we're not going to, we called Dr. Weinstock and said, what do we do in this situation? And he was like, you can pause them if they have a legitimate circumstance to where they can't make their appointment. And we've had a couple others who just missed for no good reason. Of course, we called Dr. Weinstock, and he said that the appropriate, and these were all suggestions. He's never been dictatorial about it or anything like that. He said that maybe you could take him back to week 1 for 1 week. And then whenever he keeps those appointments, then we elevate him back to where he was. And there was a tough conversation about that, but he eventually came around, and now he's actively engaged in services and hasn't missed in a few weeks. So.
Thank you so much, Scott, Melissa. Also, thank you to Shonda, who I saw helping out with some questions in the chat there too. A couple of people in the chat had asked, in case anybody didn't see that, who the funding source or what the funding source for this grant was. And Shonda said Department of Mental Health, Division of Behavioral Health, as part of the SOR 2.0 funding. Is that right, everyone? Okay, yeah. Awesome. I see we have another question, or a couple other questions in the chat too, but I just want to kind of add to that question a little bit and ask you all if you know of any funding sources currently for contingency management. It seems like that's something some of the audience might be interested in. Is there still funding available through DMH for this? Anybody know?
Yes, I can comment a little bit. So DMH has some funding through their, it's called JRI, the Justice Rehabilitation Initiative or something like that. It's for their justice involved clients. There's some funding there. DMH through the SOAR funding has a one. I think there's gonna, I don't know for sure. I don't, but there may be another call for other agencies to get involved in doing contingency management outside of that. And then lastly, I would talk to whoever your local funders are about thinking about incorporating contingency management, because there's such a strong evidence base that they may actually become interested in time along those lines. And I could help you craft being persuasive if you were interested, because I just want to see CM being used.
Awesome, thank you. We have a question from Alan with CASA, Court Appointed Special Advocates, asking, and Alan, feel free to unmute yourself if you want to elaborate on this in any way, but he is curious as to how we can use this information in CASA advocacy. Any ideas on using the information in CASA advocacy or in things maybe kind of other avenues in addition to substance misuse? Mercedes?
I was just going to say that I guess, Alan, you're maybe thinking about how we might reinforce parents, and because CASA obviously works with parents in our who are in our juvenile justice system where their kids have been taken into care. So I think maybe that's what he's thinking about. And I would say that Educare here locally does have it's kind of a system of CMT in the sense that when they attend parent cafes, which is like a parenting class, they are given rewards in the form of credit that they can use to buy toys and clothing, whatever they need for their kids. So it's not directly given to them. It's actually a credit that they can then spend on their kids. And I don't know if that's the sort of thing you're thinking about, but I know CASA, that their primary goal is to advocate for children who are in care. But typically the way we do that is to support the parents and their ability to reunify. So I don't know. I just thought I'd put that out there. I'm not sure if that's helpful.
And I think that Dr. Weinstock, you had mentioned before using, you had mentioned when we were speaking, I think once before, using CMT for people maybe who have challenges with gambling. And it seems to me like it could really be used with just about any target behavior, as long as you just narrowed it down and identified the one behavior that you wanted to reinforce, and then also that you ensured that what you were using was reinforcing. I just keep coming back to that because I know some folks know that I do some dog training, and you may find that you're not getting a behavior you want because the same thing that you're using for one individual is not in fact reinforcing for another one, which I really like, that you all use that Tango where they can choose from like 200 options.
Yeah.
They get to pick what they want, and it's probably also reinforcing to be able to make that choice,
Yes.
So I think it, with a little creativity, it could probably be used for CASA, whether trying to, shape a parent's behavior, or for just about anything, as long as that target behavior was really identified in the reinforcers. Yes, go ahead.
I don't know CASA besides what's just been shared here, but there's also contingency management has been incorporated into multi-systemic family therapy, which is a intervention that's used for substance use in adolescents. And so again, it's really around, in those instances, it's around reinforcing behaviors that are consistent with not using substances and also some drug abstinence. So if in your parents, they're using substances, CM could be used in that way to reinforce both drug abstinence if that's an issue, but also engagement in sort of the behaviors that you want to see happening on a regular basis, but you only got to pick one. You can't do a whole menu approach, because that really weakens the efficacy of contingency management, because you want your patient, your client, consumer, whatever the label is that you're using for that individual, you want them to be focused on one thing, and it's the one thing that you feel like is going to have the most impact.
Sorry.
Go ahead, Scott.
I saw a question in there. Why were you not interested in using it for testing from Mercedes? And we test our consumers all the time. We do a lot of drug testing here at the Gibson Center, but we didn't want the incentive to be contingent upon a negative UA. We wanted them, we're more interested. I mean, of course we want them to be in recovery, but we're more interested in getting them in the door. And if they had that hanging over their heads, they may be less likely to come in. If it was contingent upon, they'd just probably blow off the whole appointment if they had slipped. And so we were more interested in, if they had slipped, still coming in, still troubleshooting, relapse prevention, so that they don't continue to slip and that they, go further down into that rabbit hole of addiction.
And we can't treat them. Yeah, we can't treat them if they're not coming in. So that was just overwhelmingly the most important thing, is that they're walking in the door, that we're able to lay eyes on them and to see them. Also, like Scott said, we do a lot of UA testing, but in some of our clients' minds, it's associated with law enforcement or their PO. We wanted it, we always want it kind of separated. We're a treatment facility. We don't work for probation and parole. We work closely with them sometimes, but we wanted it very separate from that. Definitely. And I see a question from Christy. Yes, you can call Gibson and we can get them in.
And Shelley, I was just going to clarify my question about SAMHSA. So we're talking about DMH at the state level. I'm just wondering how the feds, because EPIC is supported by a SAMHSA grant. Yeah, I know Jeremiah is going to be able to speak to this probably, but you know, they always are warning us about the use of incentives, and that's that magic language they use is incentives. So how do we get around that with SAMHSA?
Do you want me to answer, or is there somebody else who's going to jump in? So that is the elephant in the room. In a sense, SAMHSA has clear rules around financial incentives and in the frame of kickbacks is their concern. And so currently SAMHSA has said basically you could, using their funding source, you can only do $75 total in a calendar year in terms of giving financial incentives to a client or a consumer. Which, based on what we know from the research literature, is not a sufficient magnitude of reinforcement. I want to just heap praise onto Gibson in terms of their approach, in that they're adding another 4 weeks and continuing to escalate the reinforcer available such that it's actually an efficacious dose of contingency management. So, I mean, these individuals are to be praised over here. These guys are doing it awesome. And I wish many other treatment agencies would have that belief in contingency management. I think in time they will. There is a national movement to really push back and on SAMHSA. There's some people who are working to say, like, look, you got to change this policy when it comes to contingency management. That all takes time. There are other instances in the federal government where, such as the VA, where they're using contingency management and they're offering up to $300 in reinforcement over a period of 12 weeks. So there's examples of the federal government allowing this to happen in other cases. You can also, I think with Medicaid, I think it's Medicaid or Medicare, you can kick back a certain proportion of incentives to people up to a certain amount that's much more higher than $75. So there are just other examples of this within the federal government. SAMHSA just needs to kind of come around. You can also, if you are so hot on this issue, you can appeal to SAMHSA for an exemption. There's been one organization that had done this, but it takes like 6 months to a year to do. And it's a lot of paperwork and some lawyers. I don't recommend it.
Well, thank everybody so much for answering all these questions and for everything that you've shared so far. And we still have some time if people have other questions. I have just put in the chat window a link to a survey that we would really appreciate it if everybody could fill out. It's a pretty short survey just to just ask some questions about this presentation and kind of evaluate how EPIC is doing with these and how you all liked this. So if you could please fill that out, that would be great. And I just, this is a topic, I just love it. I love behavior analysis and the idea of contingency management. And I love that your target behavior over at Gibson is attendance rather than something like focusing on those UAs, which obviously the end goal is that people, you know, hopefully people will stop using, but like you said, I think, Melissa, you have to get them there first, you know, so I love that that's your target behavior. And I've just enjoyed all of this, everything that we have learned today. I also kind of wonder about stimulant misuse in particular and contingency management with that, because I think that like when people are using stimulants, they're probably getting a lot of dopamine kind of hits all the time. And I wonder if that that excitement that Scott kind of talked about, ooh, I got the gift card, you know, or ooh, I won the thing and now I get to pick, if that is also serving as a similar kind of reinforcement, pretty different in some ways too, but maybe similar a little bit too. So that's really interesting. It looks like we might have some more questions coming in. Yep. So Evelyn would like to know if there's a good website or other resources with this information to share with others. And Jeremiah, I think you have pointed me in the direction of a few things before. Would you mind taking that one maybe? You're muted.
Yeah, sorry, I was just
You're good.
pulling up the website that I was going to send people to. So I'm going to put in the chat. This is just a broad contingency management based contingency management sort of hub of information. This is where I did my postdoctoral fellowship with Dr. Nancy Petrie. And so this has a lot of just good information out there. I think that's really where I would start. And if you have more specific questions, please, anybody's more than welcome to follow up with me via email along those lines. I'll put my email in the chat too, so that people have it.
Shelley, I have a quick question too. If that was enough for Evelyn, I think she was satisfied. Okay. Scott, I was just wondering what exactly is your plan going forward with this? Like, have you, I know you referred to it as a pilot, but are you in the program in a different way at this point? And what do you see in the near future and maybe even far future?
Well, we're gonna continue to enroll clients into the 8-week program. And then whenever the funding expires, both our portion and the state portion, we're going to meet together again as a management team. And we're going to decide whether this is something that we could, in a cost-effective way, implement into part of our regular services.
I just want to add that Gibson has used contingency management in different programs and different aspects. So that's one reason why our agency was, on board. We used it when we had a national study for NIDA in the past, and we did prizes that time. So.
Thanks, Shonda.
And when does the funding end?
I'm not involved at all in the financial aspect of it, honestly. So I just assume they're going to let us know when it does. Shonda might know more about that.
It's more about the amount of clients. Our goal target was 75, and we're not near that. So it'll go on as long as we have, haven't reached that goal.
I will say though, we went from 12 to 28 in it seemed like overnight. So you know how things just slowly, we've done presentations to Gibson staff, we've talked to them, but then you know how it is at an agency, sometimes things slowly catch on. Well, it doubled what it seemed like overnight, and I'm sure it's going to continue to grow.
And one of the reasons why we had the slow start, the pandemic definitely has had an impact, shortage of staff. We had to pause admissions in outpatient services a few times in a different location. So that contribute to, not the huge participation, but now we are flowing, we got, hiring people. So I believe we'll hit 75 pretty quickly.
Thank you.
Does anybody have any last minute questions before we wrap up here? And I would direct everybody again to the chat to please take I bet it's less than 3 minutes to fill out that little survey for us. So I'll leave this open for a little bit too, so folks can grab that link. And if we don't have any other questions, it looks like we are near the end here. So thank you all so much for coming and sharing with us today and all the information that you gave us, answering questions, and thanks for everybody who was able to show up and join us and learn today. So thank you very much.
Thank you.
Oh. Looks like we're just getting lots of thank yous and awesomeness in the chat. So thank you all there.